Yeah, I'm Dr. Diksha Pandey and you are watching Urogynecology for Beginners. So as these days we have started doing videos in a sequential manner. Last time you remember, we have shown you a surgery done by Monica, who is our fellow, and the surgery was total colpocleisis. So we are moving forward in the same direction, and today we are going to demonstrate the surgery done by another fellow, who is Dr. Sirisha, and to have little change and little more idea what we are going to do rather than total colpocleisis, we have picked up the video of Sirisha in which she is doing a LeFort colpocleisis, that is partial colpocleisis. So Sirisha, how do you feel about it?
First of all, I feel very good, ma'am, that how I have progressed under you, under your guidance and mentorship. Thankful for the whole opportunity, ma'am. It was a wonderful surgery, ma'am. Of course, as you always say, the technique of surgery is more important. You guided me throughout the surgery about how it is important to take thin flaps of vagina, how it is essential to create perfect lateral tunnels and the tunnel near the cervix to maintain the drainage and prevent the recurrence.
So one of my important idea of posting your videos for this particular surgery is that I want people, the beginners, to understand that it is not a difficult surgery. That's how I feel. See, what I am feeling is not that everybody has to feel that. So it is a sort of experimentation also, you can say. So Sirisha, did you feel that it was a difficult surgery or you thought it was an easy which everybody can do?
Yes, ma'am. No, it was not a difficult surgery, ma'am. But I will give the credit to you because of your reproducible techniques. Definitely, it is a surgery which everyone can adopt and should include in their armamentarium because it is definitely an easy surgery, short span of time taken for the surgery, good skill and less hemorrhage and beautiful depth attained at the end of the surgery.
And you don't have to think of so many compartmental repairs. Okay, now I have to do this now. It is one session, everything is taken
care of and everything is reduced beautifully, maintaining the symmetry again.
Yes. So what we will do today, as I have already told you, I am going to demonstrate the surgery which was done by Dr. Sirisha very slowly in step-by-step fashion so that you know how you can reproduce it in your own practice. So watch it. What you see here is a case of third degree UV prolapse. First defect you note here is the enterocele. When we retract the anterior and posterior wall and pull out the cervix with the help of a valsalum, you can see the exact extent of this prolapse, and I hope all of you are sure that it is a third degree uterovaginal prolapse. Now for colpocleisis, what we have to do is we have to do two rectangles, one in anterior surface and one in the posterior aspect. And how much margin you have to leave from external urethral meatus? It is 4 centimeters. So draw a straight line which is 4 centimeters away from the external urethral meatus. And then on the sides we have to create 2 side channels. So we have to keep a 2 centimeter strip on both the sides. Now we are cleaning the markings so that when you start doing, you learn to put the correct markings. That's why in the beginning you should use a pen so that even if you draw a wrong line in the beginning, you can correct it. So a straight line is drawn here now, around 1 centimeters away from the external os. And this line completes the rectangle, the anterior one, and helps us to create the side channels. For drawing the posterior triangle, we hold the posterior lip of the cervix with the same vulsinum, and exactly in the same way, almost mirroring the anterior rectangle, a posterior rectangle is also created. When you do your initial steps perfectly, obviously your surgery is gonna be good. So pay attention to detail, and in the beginning, it's okay if it takes little extra time. Can you see the scarred area in the center of this posterior aspect? So we have to remember that we have to be careful here. Exactly as we did in the anterior aspect, we are creating a similar rectangle in the posterior aspect now. The principles are same: 4 cm from the margin, that means from the posterior fourchette. Leave 2 cm on either side, and 1 cm margin should be left from the external os. As you see that the ink is very light and it is fading off fast, so what you can do a permanent marking on these lines which we have already measured, almost measured and drawn properly. We mark it with the help of a monopolar cautery pen. Just make tiny dots all around it, so it will help you throughout the dissection. Do the same procedure on the posterior aspect too. Usually before this step, you would have seen us sometimes infiltrating, but it depends from case to case. Today the ink of the marker pen is not very good, so you can go ahead, first make your markings permanent, and later we can go forward with other steps. As the marking is over now we can infiltrate it. So infiltration is done with the help of cold diluted adrenaline solution. And the angle of this needle should be around 0 to 15 degree for a uniform distribution of the fluid which you are injecting inside. The purpose of this infiltration are two here. Number one, to create hemostasis. To create hemostasis means to give you as bloodless field as possible, and number two is to create a bubble of safety. After this starts the actual dissection. We start the dissection with the help of monopolar cautery pen. Now a question which may come to your mind is how deep you can go with the cautery. So for this the answer is that 2 to 4 mm is the safe depth of dissection, and usually you have to decide from 2 mm to 4 mm depending upon the thickness of the vagina. Once you have made a line of the rectangle with the help of cautery, now we hold one of the edges with a small mosquito. Don't use a heavy instrument like Alice or a big clamp, because there is a chance of tearing of tissue with that. So use a small mosquito forceps, take a thin sharp scissors and slowly start the dissection. In the beginning it takes little more time as compared to towards the finishing point. So stay calm and start dissection. If there are small little bleeders, just cauterize them. If you have not seen our earlier videos, let me remind you once again that the idea here is to remove the thinnest possible layer of the vaginal epithelium, to peel off a very thin layer of the vaginal epithelium so that most of the fascia remains in situ, which helps us to repair, as you will see later. And trust me, dissecting a thin layer is more difficult than dissecting out a thick layer of tissue. It is actually an art. As we showed in our last video also, if you are a beginner and you feel that the process is little slow and you need to save some time, you can take help from your assistant too. He or she can start dissecting from the other side to help you. And trust me, the other scissors are not mine. It's definitely not important to end from where you have started. You can change the direction. It is all based on convenience. You should know what helps you best. Always remember that the ultimate idea is to remove the rectangle of vaginal epithelium, the thinnest possible layer from what you have marked, without injuring the underlying organs and an interior aspect, that is the bladder. As you will be able to appreciate here, the entire dissection is almost getting over. and the anterior side is done. Can you see the anterior denuded part? We call it the ice apple sign. On the left side is the beautifully dissected out anterior rectangle from the vagina. Let's move on to the posterior aspect, and what we will do here, exactly what we did in the anterior aspect. First, infiltration, angle of infiltration 0 to 30 degree. Can you see one scarred area on the center or little left side? So we have to be very careful here while dissecting, because it looks like that the scarring is produced because of an old healed ulcer. So we will go slow at this point. So you have to note all these changes before you start your dissection. Now once again here, Sirisha is creating a line from the dots which she has marked earlier. The entire rectangle has been outlined with the help of a cautery pen, keeping a depth of around 2 mm here. In the similar way as we did anteriorly, we hold one edge with a small mosquito forceps. Use thin scissors to start the dissection. Usually, because the aim is to create a very thin layer of the tissue, so it is better to do sharp dissection throughout. If you require in between, you can take help of blunt dissection too, but mostly it is a sharp dissection. Now can you make out, while dissecting, we have come quite close to the peritoneum. So one rule is that you have to be careful that the peritoneum should not accidentally open. So when you see this sign, you must come more close to the vagina and remove the tissue from there rather than going in the deeper planes. Can you see the translucent peritoneum? So in this situation, remove the tissue, dissect it from the vaginal wall, because we need the fascia for protection as well as for later suturing and repair. Remember, here was some scar tissue, so you have to be extremely careful at this particular dissection site. We must really try not to open the peritoneum. But by chance, during posterior dissection, if this peritoneum gets opened, then what do you do? So the rule is, do not panic and do not move forward with your dissection. First, take a 2-0 vicryl, close the rent in the peritoneum, and then move forward as you were doing before. Now you can see that we are almost approaching the lower edge till where we must dissect. The peeling off of the posterior vaginal epithelium is also near its completion, and at the lower margin where you have already drawn a line with the cautery, you can just cut it with the help of scissors. And now you can see what actually we have removed. Once the anterior and posterior epithelial layers have been removed or peeled off, half your surgery is over. Now let's move on to the second half, which is the repair part. So here the first layer of sutures using vicryl number 20, we are taking So the first layer is to make the entire canal so that cervical and uterine secretions, if any, can be drained through this. We start these sutures near the os because that is easy. So as you are taking the sutures, you remove the valcellum which were holding the lips of the cervix, and the suturing technique is the same always. So we take figure of 8 sutures, and the process, the steps of taking this suture is fascia, epithelium, epithelium and fascia. And while you tie the knot, your assistant should push the area in between inside to create inversion of the tissue and also to create a tunnel. And why this tunnel we create? So that we can insert a Ryle's tube here. So once one bite or 2 bites of sutures are taken with the help of a forceps or clamp, you can insert a Ryle's tube in this channel which we are making. This is to create a patent and throughout uniform side channel. Carefully observe once more how the bites are taken. Fascia, epithelium, epithelium, and then the fascia. And these sutures are figure of 8 sutures. Suture material is vicryl 20. Once again, fascia, epithelium, epithelium and fascia. Take it again in the same direction, fascia, epithelium, epithelium and fascia. And then tie a knot. So when you do this procedure, when you tighten your knot, the epithelial will cover the tube which you have inserted inside, thus creating a side channel, uniform side channel, which will correspond to the thickness of the Ryle's tube. And any Ryle's tube, any number, green, orange, anything is okay. There is no specific number for that. Whatever is available, you can use that. So once we have done in the center and on one side, now we move on to the another side to do exactly the same procedure. And with this, the creation of side channel is complete. Now you can see at this moment the tube is in perfect U-shaped fashion. Why I am showing you this? Because later you will realize that how this U gets converted into an inverted U. So after you have created the side channel, the next step is successive inversion of this mass. So for that, what we have to do, we have to take successive bites from both the surfaces. First from the anterior, then from the posterior. Again, you can take these bites in figure of 8 manner, and the suture material what we are using is the same. The material is Vicryl number 20. So you take a few bites in the anterior surface, and how we take figure of 8, you come on the posterior surface and take corresponding bites in the posterior surface too. And before or while you are trying to put the knot, your assistant should push or invert the in-between area with the help of a blunt forceps. In the same way, the entire row is done. Depending on the size of the prolapse, you might have to take 2, 3 or 4 bites. So see how the fascia is being held. The needle should go only through the fascia. Can you appreciate the fascia here? So we are still at the first layer, and this is the last bite of the first layer. So you have to do it step by step in a symmetrical fashion to get the most optimal results. In here, I want you also to appreciate one point. Can you see at 1 o'clock to 4 o'clock position? You can see some white tissue. So try to differentiate the pink fascia from the serosa of the bladder. So the idea is whenever you are taking the bites, you should work only on the fascia and don't go inside in the deeper planes, because then there is a risk of injuring the viscus. So what you have to do, you have to take care only the pink tissue in your bite. Pink tissue means this is the fascia. I hope you can appreciate as we are putting these knots how slowly yet progressively the prolapsed mass is going inside. So remember how it was while we were dissecting and compare it with the situation now where we have almost more than half done. See this white tissue, that is the bladder serosa, and the pink is the overlaying fascia. So you have to take only the pink part and leave the white part. Bladder mucosa is still inside, so don't get scared. So we have almost reached the edge of vaginal epithelium. So this is the last layer of sutures what we have to do. Can you see? You can clearly see the edge of vaginal epithelium, and that is the point in anterior and posterior aspect where we have marked the point looking at the 4 centimeter distance from the external urethral meatus anteriorly and from the posterior faucet posteriorly. Once the facial plication is over in a row-shaped fashion, now next we have to approximate this anterior and posterior vaginal edges. Again, figure of 8 sutures. These are simple epithelium to epithelium sutures. And tie the knots. Knots always the same. Whatever surgery you are doing, we will put the same knots. 3 knots. First will double throw, second and third single throws. So second bite in the vaginal epithelium, epithelium to epithelium, anterior to posterior. Then again anterior to posterior. That makes it a figure of 8. And with this, the approximation of edges of vagina is also over. Try to see here, when we started, the tube was put in a U-shaped manner. Now the tube has gone inside and it has actually become an inverted U. And this is the time to remove it. For removal, to decrease the length of its travel, one side of the tube is cut. Apply little jelly at this end so that you can remove it more smoothly. Pull it from the another side, and when you do it gently, the tube will come out. This is the result after completion of colpocleisis. But there is another step, which is the levateroplasty. Stay tuned, as in our next video we are going to talk in detail about levateroplasty.